So I just want to start off with a little bit of a program change. One of our speakers today, Tressie White, unfortunately has taken ill. So as we know, there's a lot of changing situations that happen, especially during the times that we're in now. And it's fitting for one of those changes to occur in a session that we're thinking a lot about health and wellness. And I think being kind to ourselves and being able to roll with changing times is a big part of managing this pandemic and this new type of conference that we're putting on this year. So thank you everybody so much for being flexible. We may be a little bit shorter today, and hopefully this will mean that we'll have the opportunity to be a little bit more interactive. And Tressie speaks very well to the effects of healthcare policy in Indigenous communities. And so we may also open it up for some of you who may have some experiences that you'd like to contribute and share, to do a little bit of collaborative thinking and idea sharing today. So thank you again so much for joining us and for being a bit flexible with our changing schedule. I just have a few brief opening comments, and then I will introduce our speaker today, Olivia Ryuta. So just a few opening thoughts. This is our fourth day, actually, of the Women's Policy Leadership Institute, and today we're going to be talking about healthcare policy in Montana. The Women's Policy Leadership Institute is a program of Montana Women Vote, and we work statewide to engage low-income women and families, LGBTQ folks, Two-Spirit and non-binary folks, Black, Indigenous, and people of color, and their allies in the democratic process as informed voters, policy advocates, and community leaders. We are really, really grateful to have Olivia Ryuta with us today, and we hope that the information presented will inform your efforts in your community, and we look forward to chatting today and staying connected as we work together to advance state policy that works for low-income folks in Montana. So I'd just like to go over a few things so that you know how to best participate in today's event. You will be muted automatically when you enter, but you can unmute yourself by clicking on the little microphone icon in the bottom left-hand corner of your screen. And if you're using the phone to join us today, you can unmute yourself by pressing *6. If you're accidentally unmuted, one of our hosts may mute you to cut down on background noise, but you're welcome to then unmute yourself again if you have something that you want to say or a question you want to ask, or if you're participating in any discussion. We really encourage you to ask questions and talk with other participants using the chat feature. You can submit questions by putting them in the chat box at any time during the workshop, and we'll either answer them throughout or we'll come back to them towards the end, and we'll be sure to pass on any relevant or unanswered questions to the panelists as we have time. You also have the option to turn captions on or off and adjust the size of your captions by clicking on the CC button at the bottom of your Zoom screen. And if you have any questions or technical difficulties as you're participating today, you can put them into the chat, or you can give our staff a call at 406-317-1505, and we'll put this phone number in the chat box as well. We are recording today's session, as I mentioned before, so if you missed something, recordings will be provided on our website, along with any materials used during the session. And at the end, we ask that you complete a short evaluation of the session to let us know your thoughts. And at the end of the evaluation, if you enter your name, you can be entered in a raffle for either a Visa gift card or a copy of the book Horsefly Dress, which is a beautiful book of poetry by local author Heather Cahoon. So that being said, I would like to reiterate for those who joined since the very beginning, Tressie White, who had planned to join us today and speak very knowledgeably to the ways that healthcare policy affects Indigenous communities in Montana, unfortunately is ill today and is unable to make it. So we are rolling with the changes as we do during these times, and we appreciate your flexibility and patience with us. We are so very excited to be joined today by Olivia Riuta of the Primary Care Association. Olivia is the Outreach and Engagement Manager at the Primary Care Association. She leads MPCA's work to identify and impact the social needs of patients that are served at health centers across Montana, including 4 of Montana's urban Indigenous health centers. Olivia joined MPCA in 2013 and worked a ton on passing the Affordable Care Act, which many folks across the country are very grateful for. Prior to joining Montana Primary Care Association, Olivia was actually the co-director of Montana Women Vote, which obviously we all love, and helped to plan and implement our voter registration, get out the vote, issue education, and ballot initiative efforts here at Montana Women Vote. Her work included policy advocacy on issues impacting low-income women and families in Montana, including access to health care, reproductive rights, violence against women, and tax and budget issues. Olivia has a bachelor's degree in grassroots development from the University of Michigan and lives in Missoula, Montana with her partner and son. So thank you so much for joining us, Olivia. I'm going to turn it over to you.
Great. Thanks, Ella, and to the entire Montana Women Vote team. I have a hard time saying no to you all, so here I am again. It is always a pleasure to be with the staff, but it's also really exciting. I was on the WPLI, the session on the Monday evening session on issues impacting Black and Indigenous folks in Montana, that conversation, and I was thrilled that there were so many people. I have gone to no less than 1,000 WPLIs, and they get better every year, even if we are in this unfortunate Zoom space. I'm with the Primary Care Association and have been doing health policy work for a long time, right? I really started that work when I was at Montana Women Vote. I started that work when I was an AmeriCorps Vista baby who moved to Montana about 15 years ago. And I feel like healthcare work is always something that I somehow think I'm going to evolve out of. I somehow think we're going to like resolve Medicaid expansion and I'm going to move on to something else. And there's just always more good work to do. So I'm going to talk about a lot of different things. Hopefully the things that you want to know, although you're going to get to tell us what you want to know in a little bit. But I want to acknowledge that there's lots of, I'm bummed that Tressie can't join us. Tressie White with Montana Healthcare Foundation is an incredible leader, and she's super knowledgeable and was the director of the Helena Indian Alliance for lots of years. And so we will do our best, but I know there's a lot of also experts in this virtual space. And so we are in a giant Zoom meeting, and I want to invite folks into the conversation. If you have comments, questions, if you want to share your perspective, please. We have an hour and a half together, so we might as well make it interesting and fun. So this is one of my favorite, when I talk about healthcare, this is one of my favorite little infographics from the Bipartisan Policy Center, because I think that we all know this, right? That there's a ton of money put into healthcare spending, into the medical services side of things. But at the end of the day, those aren't necessarily the things that if I were to ask you kind of what makes you feel healthy and what makes you well, for a lot of folks, they're not going to say sitting down with my primary care provider, right? They're going to talk about taking walks and being with loved ones. And so I think it's important to remind ourselves that as we're having a conversation about healthcare, where that money is going and where that money can or should be going. And I'm going to talk a little bit more about that. We're also talking about access. A lot of the conversation, I feel like, around health policy is about access. It's about getting folks in to see a provider when they need care. A lot of that exists in this kind of commercial insurance space. But more and more, we're having a conversation about quality, right? Are we providing good healthcare services when folks go in to see a provider? Is that care team really centering that patient? And then we also need to have a conversation about equity, because all of those things being equal, there is a clear lack of equity in how folks access care and then the kind of care they receive, and all of the other things that impact people's lives that impact their health. And we'll talk more about that as well. This is a little bit about us. If you've never heard of the Primary Care Association, I think that might be normal. We are the association of all of the community health centers across the state. So the federally qualified community health centers here in Missoula, that's Partnership. If you're in Helena, it is Peerview. In Billings, it is Riverstone Health, right? Health centers serve, they serve traditionally underserved patients, right? I pulled up about 55% of our patients are below 200% of the federal poverty level, and about 20% of our patients are uninsured, served at health centers across the state. And so health centers provide what we call, right, there's like so much healthcare lingo. I'm going to try really hard to break through some of that, but that's a great thing to throw in the chat and say, what do you mean, Olivia, when you're using your acronyms? But we call it comprehensive primary care, right? The idea that you can go in and see a healthcare provider, but somebody's having a conversation to you about your mental health. They're talking about about substance use, and that you can receive those services in that same facility with a team of providers who are all paying attention to what you need. And within that includes folks who are community health workers and kind of non-clinical people integrated into that team, so that if the thing you need most is food, that team is responding to you, and they're not simply saying, well, we can prescribe a bunch of medication to you and your insurance may pay for that, but if what you need most immediately is food, how do we make sure we're paying attention to that as healthcare teams? So we have 14 community health centers that are FQHCs. It's a technical thing. And then we also work with urban Indian health centers across the state. There are 5 in Montana. We work with 4 in here in Missoula, in Helena, Great Falls, and in Billings. That is a little bit about us. And my piece of the work is really, I'm not a clinical person, right? There's a lot of smart clinical people who are on our team. And my role on that is to say, how are we thinking about all of these things that are impacting people's health that might not be kind of a clinical conversation? So we are learning together in Zoom. One day, one day we're not going to have to do that, and we're not there yet. So you can all unmute yourself. You have that power. There are a lot of experts here in this space. But I want us to start off, I'd love to hear what folks are kind of coming into this conversation hoping to learn or find out, or I feel like so much of what's happening on the federal level is like rumors, what rumors you want to confirm or deny. Kind of what are you hoping to get out of today's session? You could be a lot of places, including having lunch and not looking at all of us. So why are you here and what are you trying to get out of here? And if you could put your name, pronouns, and then the question, if you have an organization you're part of, throw that in there. But if you could also put your question in there. And I am sorry, I'm Olivia, I use she, her pronouns. This should have started with that. So you could throw it in the chat if you want to unmute. You can also use your power. And I will pause. And
I'll unmute while people are putting their thoughts into the chat, or if other folks want to unmute after me. But I love rumors. So I'm super excited to hear a little bit about what's going on in Montana, but also maybe some slightly better news about what could be happening at the federal level and which ones of those rumors are more likely than others.
I heard some rumors this morning. I'll share them, Ella. Questions? And some of your names are obviously familiar. You guys have been, advocating certainly on Medicaid expansion and other access to healthcare issues for a long time. What are folks hoping to get?
If I may. My name is David Alanjan. I use he, him. I'm not a native Montanan. I'm from Southern California, transferred to UM in the fall of 2019. I'm looking to understand the Montanan voter and the people that are most affected by hypothetical progressive healthcare programs and what their attitudes are like regarding state versus federal healthcare policy. My sense is that Montanans generally prefer state level action, but on the healthcare question, I haven't seen anything super clear cut. So that's a really specific thing I'm looking for here.
Okay, other questions? So lots of questions about Biden's plan for Medicaid expansion. What will happen between the state of Montana and the Biden administration around expansion? How does health access and equity intersect with missing and murdered Indigenous women and people and maternal health disparities for Black, Indigenous, and people of color? Great questions, Jan. I think lots of Medicaid expansion questions and kind of where we're at with our new administration. Where healthcare is most vulnerable. These are big questions, folks. Some questions about home and community-based services, folks who are aging and people with disabilities. Great questions. And then some questions about telehealth, the Montana Telehealth Alliance. Yep, the questions about access through telehealth. Okay, all over the place. This is a great group. So what I will promise you is that we will answer some of these. We can have conversations. We'll get as far as we can. So some of the questions I'm not an expert at and am not the right person to answer them, but collectively I know we know the right people. And so we will do our best. And then I will give you my phone number and we can, if you have other questions and I can be helpful moving forward, you can have it. Excellent. So you can keep putting those questions in there and Ella's going to help kind of track them as we go through. Okay, great. So I'm going to just talk about, so in healthcare right now, right, we like to kind of talk about, things become very hip. And right now it's very hip in the healthcare space to talk about social determinants of health. And so if you've never heard this term, I'm sure many of you have, right? Social determinants of health was included in Healthy People 2020, which is kind of how the feds, there are a bunch of public health priorities, but it's a fancy word for something that we all know, right? That people's lives are complicated, and whether somebody has enough food to eat, whether they can afford to live in safe housing, whether or not they have a community that supports them, right? That if they have access to education, that all of this impacts people's health outcomes. It is something that we inherently know, and it is now what we call the social determinants of health in healthcare. I think the good news is that we're talking about the social determinants of health more than we were, 5 years ago, certainly 10 years ago, and that we are asking healthcare providers, right? And with us, we're asking primary care providers that they have a responsibility to kind of understand the other things that are happening in the lives of our patients and have some role in intervening in them, right? And for some places that intervention happens with the actual staff, right? If you're at a health center and you are identified as not having insurance, there's somebody who can sit down with you and walk you through that Medicaid application and work with you to make sure you understand how to use your coverage. But sometimes it's a referral to a partner in town who might do kind of specific housing work. But this is a conversation that's happening that I think is, as we think about state and federal health policy, is coming up more and more. And for us, I'm going to talk about some bills that aren't specific healthcare bills, because there's some of the priorities that we have identified and how our patients are impacted in these kind of non-clinical areas. This is a really wonky slide from the Robert Wood Johnson Foundation. I think the only thing that matters in this slide, you can read all the words if you'd like, but that clinical care alone can't impact health outcomes, right? You can see a provider, you can see a doctor, a nurse practitioner, a PA as much as you want, right? But if we actually want to change health outcomes, we have to make sure that we are intervening in other ways. And so I think as someone who works with healthcare providers, I think it's also a challenge to us. And what other conversations do we need to be a part of as well? And also one note, we call these in my healthcare world speak, we call, like, if you are showing up at a clinic and you identify as someone who is hungry and needs emergency food assistance right then and there, we call those enabling services. It's the language that the feds use. It's the language that the feds use, and we're switching to talking about social intervention. So how are we identifying health and social needs and then providing social interventions? So that's just a little bit, I think that background is a little bit about how we're shifting and thinking about healthcare. I think that that's good news for folks who care about people and people's ability to be well. I'm going to talk a little bit of a couple slides about health insurance coverage in Montana, because we're going to talk a lot about coverage, but it's helpful to remind ourselves where we're at. One of the things that the Montana Healthcare Foundation does really well is they put together these incredible reports that we can then use to really kind of understand and explain what is going on. So this is a report from the Healthcare Foundation. It came out in the fall, and it was put together by Christina Go, who's based out of Helena and is an attorney who works on healthcare issues. But this was an update to kind of what was our uninsured rate and how were folks covered about August, September, trying to account for the pandemic. And so what we know is most folks get their coverage through their employer, right? Employer group is either I'm employed and my employer pays for it, or I have a partner or spouse who's employed and I get it through them, or I have a kid who gets it through my employer. We know that 5% of folks are buying it on the individual market, right? And that individual market includes the health insurance marketplace, healthcare.gov. It also includes folks who might be buying it not on healthcare.gov, but with a kind of independent insurance provider. 22% of folks are on Medicaid and 22% of folks are on Medicare, right? Medicaid is a program for folks who are low and moderate income, who are not Medicare eligible, right? And so these are folks primarily folks who are low-income folks, people who have families, people who have disabilities, who might be eligible for both Medicare and Medicaid, and then a bunch of kids. There's tons of Montana kids who are enrolled either through Medicaid or the Healthy Montana Kids program. Medicare, folks who are over 65 or folks who have disabilities and are eligible for Medicare before them. And then we have about 10% of folks who are uninsured. Right. So I think that because I spend a lot of time in the kind of healthcare.gov health insurance marketplace space, and that's 5% of how Montanans get coverage. And for those 5%, it's super important, but most people are getting their coverage in other ways in the state of Montana. And what we saw during the pandemic, also not surprising, is that our uninsured rate went up. Our uninsured rate, to be clear, like 20% in 2013 was, the ACA was passed in 2010, and the first open enrollment period happened for folks to buy into the health insurance marketplace in 2013. Medicaid expansion in Montana started in 2016 on January 1st, and you can kind of see those different points. But what you do see is in the last few years, our uninsured rate has been ticking up. And I think there's a lot of reasons for that, in part because there's been a disinvestment on the federal side in outreach and enrollment help for the healthcare.gov. But also, I think there's been, a lot of questions about Medicaid expansion, right? It's an ongoing, everybody said, I want to know about Medicaid expansion. It's been a conversation we've been having for a really long time. And so I think sometimes people aren't sure. And so if we look at our Medicaid numbers with that kind of saga of expansion, I think some of our Medicaid drop off we saw because of that. And you can find this report on healthcare.gov. I'm sorry, not on healthcare.gov, on the Montana Healthcare Foundation website, and that is available. They have tons. I will also have slides, some other Medicaid slides later, but they have tons of incredible reports. Are there any, and Ella, just jump in, just interrupt me, please. It's hard for me to pay attention to all the things. And then my boss is always calling me, it seems.
I will, we have a lot of great questions. So I think if there are places that you just want to take a pause and address a couple questions, that might be the best way to handle it.
I'll answer this one and then we'll take a pause. So just as we think about the most recent open enrollment period, right? So in response to our increasing uninsured rate, in response to the so many folks saw their hours cut, their incomes go down, they lost employer-sponsored coverage because of COVID. We saw about a 2% increase in our marketplace enrollment, right? That's that kind of 5% of Montanans. That's how those folks get their coverage. But that's the health insurance marketplace for folks who are below, who meet Medicaid eligibility. They're getting enrolled in Medicaid, and you can kind of see this chart is enrollment by month since the beginning of Montana Medicaid, and this is the Montana Medicaid dashboard. We can put that link in there. I don't have it right now, but you can see we saw both a marketplace increase, and then we also saw a big response in 2020, Medicaid doing what Medicaid is designed to do, to be the safety net. And as folks are losing coverage and and folks are needing coverage, really enrolling. And we saw a lot of folks who enrolled for the first time. Part of the work that I do as part of the Primary Care Association is we facilitate this thing called Cover Montana, right? It's all the folks who do outreach and enrollment work for healthcare.gov, but for also, they do a ton of Montana Medicaid enrollment. These are certified application counselors at organizations around the state. And so we track this stuff pretty closely. And it was a really busy open enrollment period with lots of folks who'd been impacted by COVID or had questions. I'm gonna pause. Ella, questions?
So we've had two questions that I think are very relevant in the moment. And then I'm sort of keeping track of a lot of the broader questions that folks mentioned at the beginning, and we may come back to some of those a bit later. Do you know, or can you share a little bit more about what demographics comprise the 10% of uninsured?
I don't, maybe. I need to look at that report. I don't think that report. So So uninsured data is really complicated. Because of the way that it's reported, right? So we get all this data from different sources and then we add them up, right? There isn't like a data source where folks who are uninsured kind of put their information in there. So I think uninsured data is not great. It also, we're always getting we're getting data from a year before. So during the pandemic, especially, it's really hard to kind of know in real time what's happening with folks and specifically who those people are. Historically in Montana, we pre-ACA and pre-Medicaid expansion, we had the highest rate of Indigenous folks who were uninsured and the highest rate of veterans who were uninsured. And so that being said, the other thing that we know about all those uninsured folks is that the #1 reason they're uninsured is because of cost. And so a lot of, if you think about demographics, a lot of folks are above eligibility for Medicaid, but they might be eligible for some kind of a tax credit on healthcare.gov, but it's still unaffordable for them, right? Their monthly premium might be unaffordable, and then to actually go and see a provider might actually be quite unaffordable based on the kind of max out-of-pocket costs that exist on marketplace plans, which we can dig into more. But so I don't have good data about who those uninsured folks are, unfortunately. But I think that's a great question. And I can double check in that report from Christina Go, but I don't think it has any more information.
And then any thoughts or perspectives on why Montana's Medicaid enrollment did not increase as much as other states did?
During the pandemic? Yeah. I think that, yes, I think that one of the things we saw in other states kind of immediately was the state stepping into the lead and doing a bunch of outreach, right? So like kind of day one of the pandemic, right, connecting the dots between folks who were applying for unemployment insurance and making sure they had Medicaid information, and we're kind of taking all of the barriers out for folks. We didn't do that in the same way that other states did, so I think that that's a big piece of it. I also think because we're a federally facilitated marketplace state, we use healthcare.gov, right? Some states use their own state-based marketplace where they get to decide a whole bunch of stuff, including states with a state-based marketplace. When the pandemic hit, they opened up they had a special enrollment period for folks, right? And so what open enrollment periods for the healthcare.gov marketplace do, or a state-based marketplace do, is they catch folks who are eligible for Medicaid also, right? So people show up, they say, oh, I'm uninsured, I don't know what I qualify for, and they might have been thinking that they were eligible for a plan, a marketplace plan, and so they're applying and they might actually be eligible for Medicaid. So we catch a lot of people who don't know that they qualify. So I think those are two things. And I think as we're thinking about a pandemic that moves forward, those are things that would really help strengthen. I mean, we're going to talk, there is a new special enrollment, a federal special enrollment that will help. But I think anything the state can do to communicate to folks who we already know are impacted is a really smart way to go. Okay, other questions? Should I continue on?
Let's continue for now, and I'm still keeping track, so folks feel free to keep asking these great questions in the chat.
Please, please. And we're going to talk, I have some slides about Medicaid enrollment and the demographic breakdown a little bit later. They got a little flip-flopped around because of our last minute shifts. Apologies. So I want to kind of flip to talking about some federal policy pieces. We're going to talk about kind of rumors at the federal level. What do we know at the federal level? Some of which could have really big implications for Montana. And then we're going to dig into some some of the things that we are tracking on the state side. And so I want to start, this is a slide I stole from our friends at an organization called APCHO, the Association of Asian Pacific Community Health Organizations out of Oakland. They do incredible work But these are some health-related executive actions, right? There's been a ton of executive actions. There always are in every administration. But these are the health-related executive actions that we have been tracking. And this is probably not news to anybody. There's just a ton of COVID-related executive actions happening. And then we're also going to talk about the 2 COVID relief bills and some of the things that we're tracking in there. So the one piece as we're looking at one of the things that we are tracking is kind of what is happening around the health equity task force that President Biden now has, right? What we've seen is, right, systemic structural racism has put Black, Indigenous, and people of color at greater risk of contracting COVID and dying of COVID. This statistic out of The Guardian, it is a recent article. It's a really great article. It really shows the kind of disproportionate impact that Indigenous communities are facing in terms of COVID deaths. And what I will also say, we track the COVID data, right? And so understanding equity in COVID is only as good as the data that we have. And so in Montana, we have reported race data for 78% of COVID cases and 85% of deaths, which is better than some states, not as good as other states. We don't have any race data if we're looking at COVID testing. And so I think that one of the things that we're thinking about and it brings to light in all of the inequities in how COVID has impacted Black, Indigenous, and people of color, is that we see that, and our data matters so that we can identify kind of what is happening where, and so that we can also assess how to improve that work. And so so we're tracking this health equity task force. One of the things that happened yesterday as part of this, community health centers are going to get direct allocation of vaccines, right? We see we see inequity in COVID in every way possible. We're seeing it a lot in vaccines in terms of who should be at the front of the line and who's actually getting those vaccines. So we're excited for the direct allocation, because what a health center can do is look at a patient population, identify folks who have a diagnosis of diabetes and who are below 100% of poverty, and who identify as Indigenous, and who are also housing insecure, right? Like, we can be really specific and targeted in folks who should be getting that vaccine first in a different way than Walgreens can. And so I think that it's exciting that this work is happening. I am by no means an expert on how vaccine distribution has happened with IHS, tribal health, or urban Indian health center programs, right? There were a lot of decisions about, anyway, there's a state approach, and then then IHS has a different allocation structure of vaccines. And so I'm not sure how the health equity task force is impacting some of that vaccine rollout. But these are but this is what we are thinking about and tracking and trying to understand as we have data conversations and as we are in rooms, that we have to, if we're to understand what's happening, not happening, that the role that data and being able to tell that story, because what everybody will say is these inequities are completely unacceptable and likely underreported because our data doesn't have integrity. So the other executive order I want to highlight, we have a new open enrollment period. They're calling it a special enrollment period. I think that a special enrollment period is a little misleading. It is essentially like open enrollment, right? Like, anybody who's uninsured can go to healthcare.gov starting February 15th through May 15th. Even if you're enrolled in a healthcare.gov plan, you can change plans, you can change your meta levels, you can do all of that stuff. So we're pretty excited about this. It includes a $50 million outreach and education budget. There were huge cuts under the Trump administration to outreach and enrollment budgets. And so I think that this is a good sign. I think that there's still big questions around affordability, I think some of which we get to talk about. I think we might have a chance to address. We have this conversation and we talk about federal poverty levels all the time. And so I'm going to take a break and show you a chart, and hopefully this isn't more confusing than less. I'm going to show you two charts. These are some of what we use when we're talking about eligibility for health insurance coverage programs, right? Whether it's a public program like Montana Medicaid or Healthy Montana Kids, or a private plan sold through healthcare.gov, but with tax credits to make your premium more affordable, or this thing we call cost sharing reductions, which just means it's more affordable to actually see a provider. So this is where we are at now. If you're a family size of 2, it's also, you're welcome knowing that, you know, Medicaid and HMK are based on a monthly basis. And when you're looking at the health insurance marketplace, it's yearly. So, but when we're talking about eligibility levels, a family of 2 is about $19.83 for Montana Medicaid. So that's the ceiling. And then above that, you'd become eligible for the health insurance marketplace all the way up to making just under $70,000 a year, right? And the more you make, the smaller your tax credit gets. And at some point, your cost sharing reductions kind of fall off. And so, but just want to stop because I think we talk about eligibility, we talk about how people kind of move between programs. That's what the eligibility looks like. If you look, if folks are enrolled members of federally recognized tribes, you have a new chart that is also confusing. Both Medicaid and HMK, but then there's special provisions for Native Americans within the Affordable Care Act for healthcare.gov plans. This is only for folks who are enrolled members of federally recognized tribes. And so if somebody is a descendant, they don't qualify for these provisions. But there is a limited cost sharing provision that you can kind of see on the left side of the special provisions. I'm sorry, it's on the right side. And then there's a zero cost sharing provision. So if somebody, if one person who is an enrolled member of a federally recognized tribe, if they're a tax household of 1, makes less than 38,280, then that's a zero cost sharing plan. You pay your premium and then there's no out-of-pocket costs after that fact. So I don't think I actually think that has confused all of us even more. I talk about this all the time, but I think it's important to understand how these programs kind of fit together. And there is confusion, and a lot of what we do working with folks is kind of walking them through the process. The only thing we know about outreach and enrollment is that somebody is way more likely to enroll if they talk to somebody who can walk them through the process. Okay. This you already know, none of it is surprising. Why are people uninsured? This is pre-COVID. We had an unaffordability problem pre-COVID. And since I've started doing healthcare work, nobody, pre-ACA, right? People still wanted health insurance. They still couldn't afford it. Okay. So can we fix or strengthen the ACA? I feel like this is a big question on the federal level. And so there's a couple of pieces that I think are the most compelling that would actually make an impact on Montanans. The first is the family glitch. There's some unfortunate unfortunate ways that the Treasury has interpreted the ACA to assess what is affordable for a family, but essentially folks who have if they have a spouse or a partner who's offered coverage and they're offered coverage, it can sometimes get wonky and somebody isn't eligible for a tax credit. I can go way deep into that. I think that on the things that we think could actually happen, I think that that's pretty far up there. And that would go a long way for folks I think that people get caught in this, and they're kind of lower moderate income people who might qualify for a good tax credit that, that they could afford a premium, and then a plan that would get them access to coverage. And so I think the family glitch is an exciting one. I think the biggest thing is addressing affordability, right? Reducing out-of-pocket costs when accessing care, and then making sure that people can actually afford their monthly premiums go hand in hand. I was on a call this morning, rumor, that the House version of the new COVID relief plan, which I can't remember the name of, it's Rescuing America in some way, it is increasing the threshold, like what's the upper limit of tax credit eligibility. And so increasing the tax credits that folks receive, which would make those premiums more affordable. We have yet to see, right? It's great to have a insurance plan, but if you can afford your premium and you can't actually afford to go to a doctor when you need to, right? That doesn't solve the problem. And so I think there's still questions about how do you actually ensure that there is affordable access to coverage. We sometimes call that first dollar coverage in my world. I think that there's some weirdness, right? Veterans, we have a ton of veterans in Montana, and who are traditionally uninsured, and who traditionally have a high rate of uninsured. And if you're eligible for the VA, even the lowest level of benefits, you can't get tax credits, which is real problematic for a lot of folks. And so the same isn't true on Medicaid, right? If you're a veteran and you're eligible for VA benefits, you can still enroll in Medicaid. So that's, I think, another fix. I've heard no rumors about whether that's a possibility. A big question that we get is like, where is this public option conversation? Like, is this going to happen? I am not an expert on what the Senate can or cannot get through. Everything that I've read is saying that the more likely public option conversation is happening in states than it is happening at the federal level, right? Washington's bringing on a public option this year for AppleCare, Washington State. I think for Montana, right, we are likely not going to have a public option if it's up to our state. And so I think that there's still a question about that. And then there's some questions about what's going to happen with these association health plans and short-term limited duration plans. You might have heard about them. These were some changes under the Trump administration, which essentially said, hey, health insurance is too expensive. Let's create these non-ACA compliant plans, and then they'll be more affordable, right? I think the problem with that, especially those short-term limited duration plans, is that it's the bad old days of your health insurer being able to discriminate against you, whether it's your health status. And like in Montana, Christina Go did another great paper looking at short-term limited duration health plans in Montana. And none of the plans she looked at were over 6 months in duration, because then they didn't have to pay for any pregnancy-related costs, right? They'd screen you, see if you were pregnant when you applied. If you were, you get denied, and then they never have to pay for pregnancy-related costs. So, I mean, it is the way that health insurance existed for a long time. And so what I'm hearing about those plans is that there hasn't been, while we certainly have them more and more in Montana, the short-term limited duration plans, which are mostly out-of-state brokers, right? There's not that the administration isn't going to prioritize rolling those back as much, because the impact hasn't been as great as folks thought it might be on ACA compliant plans sold through healthcare.gov. I'll pause there. It's hard to not see your faces.
So we do have one good question that I think would potentially belong here, which is, do you see the new presidential administration having any plans specifically for changes or expansions to Medicaid expansion for states? Mm-hmm. And would, if that were to change, would our legislature have to then vote to adopt any new funding?
Great question.
Any
I'm
new
going to get
federal
to that
dollars?
question. Don't worry. That's
Okay,
coming
great.
up, but that is a great question. Yeah. Okay. I'm going to go to my next slide. So 2 notes, and then I think we're running behind and we need to like talk about Medicaid expansion for a few hours. I know that there's lots of questions I get, like what's going on with healthcare in the Supreme Court? It's still moving, right? California v. Texas, which is challenging. I'm sorry, it's not a challenge to the entire Supreme Court. It's a challenge to the entire ACA. It's pending before the Supreme Court. It was heard in the fall. It's trying to throw the whole thing out, right? If the individual mandate is constitutional, it is unconstitutional. If the individual mandate remains constitutional after Congress kind of zeroed out the penalty, can they throw out the entire law? Smarter people than me say that this is, of the many Supreme Court challenges to the ACA, this isn't the strongest one. And so that I don't think there's as much worry about this piece. I think looking at what the future of our Medicaid expansion program in Montana, these Azar v. Gresham and Azar v. Philbrick, so they're really looking at the legality of Section 1115 waivers with work requirements. These are in Arkansas and New Hampshire. The lower courts ruled against the administration in both cases, right? The Biden administration isn't going to defend these work requirements. That's the expectation. We were hearing early on that those cases might get, right, that the administration was going to try to resolve this and those cases might get pulled. I think that there's some smarter people than me are also talking about that the court might want to hear these cases, right? This is a more conservative court that might be interested in hearing these cases. So kind of less likely and willing to kind of throw them out because there's a change in administration. And throwing them out is the wrong term. And I wish that SK Rossi was on so they could correct me and tell me what I should be saying in terms of legalese. But I think that, so what I hear a lot is, isn't the ACA going to go away? Should I enroll in a plan? And I say, nothing's going to happen until it happens. Also, if anything were to happen, right, the expectation is that Congress would act in some way, and that there would be pressure to not have the entire ACA go away, because, you know, even if somebody doesn't like Medicaid expansion, even if somebody doesn't like tax credits, and the way the ACA is structured, it kind of fundamentally changed health insurance laws. And so it would just create chaos in health insurance markets that have huge implications just beyond the healthcare.gov and Medicaid expansion. Please don't ask me any legal questions. Going forward quickly. One thing to note that we've been tracking is what's happening with public charge and health coverage programs, like public charge at large. So in February, Biden issued an executive order directing agencies to review the public charge immigration policy, but the kind of timing of the Trump administration policy is that they just can't kind of do away with it overnight, as I understand it. So the policy remains in place and it's under review. I think that this is an example. Most folks who are eligible for Medicaid are not subject to public charge rules, right? This is an example of a policy whose the intent is really to scare immigrant families and to scare them and to discourage them from enrolling in programs and services that they qualify for and won't have an impact on their public charge assessment. And so it's really a strategy of fear and intimidation. But I think that this is a great resource from Health Reform Beyond the Basics, which is out of the Center on Budget and Policy Priorities. And I think helps to remind us where we are at with public charge, but that most folks, we can talk about Medicaid eligibility. We can dive deeper if that's a question, but certainly in Montana, that is what we see, that folks who are subject to public charge aren't eligible for Medicaid. There are a lot of folks who are not subject to public charge, I mean, there are a lot of folks who are eligible for services, and those services don't count toward public charge, and they are programs and services that we absolutely want folks to enroll in, that ensure access to coverage, that ensure that folks have their needs met. And so I can send this out with my slides. I can send the link, but I think this is a nice summary that's pretty clear. Okay. Some highlights from COVID relief bills. There was some really great, so the December 2020 COVID-19 stimulus bill, I'm calling it that. And then the proposed American Rescue Plan Act, calling it that, right? There was the December bill that passed. There is the proposed bill that is moving through and is getting worked up in the House, so I hear. So there was some great analysis from NCUI, which is the national organization that works with urban Indian health centers, about there are some great investments in urban Indian health as part of that. Just increases to the FY21 budget and looking at infrastructure, and then some interesting reimbursement stuff where if somebody is eligible for services at an urban Indian health center, but they're also VA eligible, the VA is going to reimburse that center. There's money for testing and vaccines kind of all over the place in every bill. It's hard to track. I am not an expert. And then the other thing I will say is I included kind of pretty wonky stuff about like National Health Service Corps, Nurse Corps, teaching health centers. Not that the only thing that matters in that is in Montana, workforce matters, right? Like it is hard to get people to move to Montana and practice medicine. It's easier in Missoula than it is in Cut Bank. But it is that there's a lot of workforce focused programs that really look at loan repayment that are super important if we're going to actually recruit and retain providers in rural areas, in Montana at large, and especially in more rural areas. And so I included those in there. I don't have a good, I wasn't able to find kind of a good specific breakdown about the impacts to tribes and indigenous folks with the proposed American Rescue Plan Act, because it's all just now, I feel like I'm just starting to get details, but I think that that's a big question mark. We talked a little bit about telehealth, right? We're going to talk more about it. But I think that the December stimulus bill, there was $7 billion for broadband, $1 billion was for tribal broadband. So as we think about how do people access care during a pandemic, how do they learn, how do they work, a really important infrastructure piece, and making sure that folks can actually have access through the internet. I'm going to pause there. Okay. Whoop. Oh man. Fail. Oh, I'm so sorry.
Olivia, we did actually have a COVID related question that I could pose, and then you can let me know if maybe it belongs later.
Yeah.
Someone was wondering about the 7 county health directors who have quit across the state as extremist county commissioners defy the COVID information by experts. And so how do we pick up the slack for that lack of expertise? Or is there anything that you would like to comment on as regards to those, you know, some of the experiences of those county health directors? I know this is a little bit
there's so
off
much
the main topic, sort of, but
no, and we are tracking kind of all of those bills that are really trying to take away kind of local public health's authority to act in the event of a public health emergency or not a public health emergency, right? Like it's just trying to erode local public health authority. I think it's really, I mean, what we see, right? Community health centers have been working with their public health partners, and everybody doing anything related to COVID is like, they have been working nonstop since March. And so we are really concerned right? When folks are targeted and harassed, and we lose all of this capacity to actually respond. I think it's really hard for communities. I think it's really hard for communities to then, you know, who's going to raise their hand and step in and say, hey, I'd love that job. Can you please, like, you know, put my phone number on the internet and harass my children? Like, obviously, it is really at a time when we need people most. I think it's very concerning. I think that in some of the, what's exciting is that there's like, in this proposed American Rescue Plan Act has a bunch of money, I can't remember how much, in public health workforce. So an acknowledgement that we need to be investing in public health workforce. Public health has been underinvested in for a long time coming into this pandemic. But what I think is interesting about that is like this CHW means community health workers. That allowed under that money is community health workers are folks who are from a community, right? Who have some kind of lived experience with the community that they would be serving. They're similar to peer support specialists in a kind of behavioral health context. But a lot of places in the world and a lot of places in the US use community health workers. And so it's really kind of a non-clinical member kind of engaging their community and responding to need. I think that that's really helpful and exciting, because if we, the more people we have who live in communities, who are engaged in communities doing that work, I think it helps to, I think it's helpful in the end. I don't have a solution, and I don't know how we, kind of reinvest in public health and make it a safe place where people want to do work. I think that that's a big challenge in especially small communities that we're going to see for a long time. So I have no solutions, but I know that when we talk to our centers, they're talking to their public health, and that some folks, you know, have had 5 days off since March. And so, yeah. That's a great question, and I have no solutions. Okay. I don't know why that's there. This is my example of just how we think about, like, if we're identifying patients who are most vulnerable. But that slide got moved around. My apologies. So some state policy pieces, I have a couple handfuls of bills that I want to talk about that we're tracking, Medicaid being one of them, and probably the biggest one. So I will move quickly through some of the other ones. So right, and I think, Ella, did you guys already talk about kind of Ledge 101? Did you do that yesterday? Great, right? So you probably talked about cat and dog bills, and you talked about budget bills. So these are a handful of some of the cat and dog bills that we are tracking, right? There's the whole budget process that is happening on this one side, and then there are all of these great or not so great ideas that land in cat and dog bills. And this is a mix of both great and not great ideas. And so in thinking about, House Bill 222 is an example of like how we're thinking about really specific access and cost issues, right? Insulin is very expensive. And so this was a bill capping insurance copays at $35 for each 30-day supply. That bill was tabled in committee. And I know there was opposition from a lot of the health insurance carriers to that bill, but that's a specific need that we see, right, with our patients. I will say that I think that in 2021 plan year marketplace, some of those plans have better insulin coverage than we have seen in past years, which I think is exciting, that we're seeing a little bit of an improvement to that drug formulary in some areas where people have high costs. But we're bummed that that bill was tabled in committee. There's efforts both at the, right, so telehealth, it's all about what payer says they will pay for telehealth, right? So in Montana looking at making sure Medicaid is paying for telehealth, and then making sure that our carriers, our private health insurance carriers, the Blue Cross Blue Shields of the world, are paying for telehealth as well. Telehealth is very popular. Nothing passes the House 100-0. And like not even a Huckleberry pancake bill. And so I think that it's exciting that this bill is moving. What's happening at the federal level is lots of conversations about extending the telehealth authority. Some of that is really focused on Medicare, right? Because the feds have to decide that piece. And so how do we make sure we have the federal piece in place and then the state piece in place so that we can actually provide telehealth services and people can get access to care that way? Paid Family and Medical Leave Act. This was heard today in House Business and Labor. Some of you probably testified on it, right? We have a pandemic and people don't have leave. And so one of the things that we are supporting, and there's just a very clear line between people being able to be healthy and families being able to make ends meet with this bill. We are House Bill 21, the Coal Trust Home Loan Program, right? We take 15 million out of the Coal Trust to invest in affordable housing. It's asking for $15 million more to kind of work with developers and invest that money. And so there's no action yet on that bill, but we have an affordability crisis in the state of Montana that's only been exacerbated during COVID. The House Bill 113, really an anti-transgender care bill targeting providers about providing gender-affirming care to folks who are trans. That bill died on the House floor. I don't know where my exciting bullet, it was going to be all caps. I know a lot of folks on this call did a lot of work to kill that bill. We're tracking healthcare sharing ministries. Again, kind of one of healthcare sharing ministries are along the lines of non-ACA compliant things that seem like insurance and don't seem, sound like a fine idea, except they don't provide the protections that health insurance provides. And so we talk to folks in the outreach and enrollment world, and I have concerns about people not knowing what they're signing up for, because there's no guarantee that, if you have a medical emergency, the healthcare sharing ministry is actually going to pay. Senate Bill 100, Welfare Fraud Prevention Act, the biggest bill that we've seen, really, which is in opposition to Medicaid expansion, but a bunch of other programs and services, really just creating bureaucracy and hoops that both require a bunch of state investment of FTEs and then pretty much guarantee that folks will not be able to navigate that bureaucracy and will fall off the rolls even when they're eligible, and should be on those rolls. It's what we have seen if you look at other states who have kind of complex Medicaid expansion, enrollment, enhanced eligibility kind of business, right? So many of those people who are coming off the rolls are not coming off because they are not eligible. They simply cannot manage the bureaucracy. I think it's important to note when talking about this bill, right? In 2017, we saw big cuts to the DPHHS budget, including the closing of 19 offices of public assistance across the state. We also have, so everybody's supposed to, and our offices of public assistance aren't even open right now. So you're calling the public assistance helpline, which over the years sometimes has very, very long wait times. And so I think there's lots of questions about not only the intent of that bill, but during a pandemic when we do not have the infrastructure. So it's just doubly bad. And then lots of bills eroding public health authority. There are lots of questions and comments. I'm going to pause there. I haven't been tracking any of them.
That is totally okay. So I'm checking into my list here, and it looks like you have mostly covered our legislative session related questions in terms of threats to Medicaid expansion and efforts to sort of curtail. Someone did ask about the new governor's attitude toward healthcare access and funding.
So let's talk about the threat. So I think there's a couple of threats, right? I think that what we're not seeing is like repeal Medicaid expansion bill signed X, Y, and Z legislator, which it wasn't clear coming into this session if we were going to see really clear efforts to straight up repeal. But I think that one of the things, so I think there's a lot of moving parts with Medicaid, right? We have a new administration at the federal level that doesn't love work requirements. And we have a waiver pending with CMS that has some community engagement requirements, which is a nice way of saying work requirements. This is my little Medicaid expansion timeline. If you forgot the saga, here it is. You can relive it in all of its glory. But essentially where we are at right at this moment is that we submitted a waiver last fall, right, that included community engagement requirements. That waiver has not been accepted by CMS. And so we are operating under our original help waiver that was extended in the fall. And so there's a question mark about kind of what's going to happen with that. But we're not sealing. So I think there's a question about what's going to happen with that. And I think it's a question about where CMS, how CMS is going to approach working with states who have waivers that have community engagement and work requirements that this new administration doesn't want to support. I think there's a question about what's going to happen with the Supreme Court that I am waiting for smarter people than me to do more in-depth analysis of once that that case is actually heard, or those two cases are actually heard. I think a big, most immediate threat other than House Bill 100 or Senate Bill 100 is House Bill 2, the state budget, right? We have the state budget and then we have our cat and dog bills. So in 2019, Medicaid was moved to House Bill 2. Before that, it was considered statutory funding. I think this was part of the negotiation. I honestly can't remember, but so we have to really kind of track that Section B part of the Department of Public Health and Human Services budget. And we are starting, right? Like these are joint appropriations subcommittees on different pieces of the budget. And so we see that Section B subcommittee starting at 2019 levels, which is almost $1 billion cut from present law. And so the idea is that we'll build that budget back up. It's a nice thing to say. It's always a harder thing to do. And so I think that we are also paying attention to what's happening in House Bill 2, because I think that even if we don't have a bill that says we're going to just get rid of Medicaid expansion and go back to the good old days in Montana, I think that if we don't fully fund Medicaid, right, then the department has to figure out what to do with that. And so I think there's a way to underfund Medicaid, which will result in cuts in a way that you're not taking a vote on the floor. You're not saying, hey, I don't think that low-income folks deserve to go to the dentist, right? That's a harder vote to take than to say, we just can't afford all of it. So you're going to have to figure it out, Department of Public Health and Human Services. So I think that this is a big deal. And I am not tracking that Section B piece. I don't know, Ella, if you or Howell have any thoughts or tracking that, or other folks get to spend their day in that space. I would love your thoughts and feedback, but I think that we're concerned about what that budget looks like, not just the specific potential attacks of those cat and dog bills.
I think that's exactly right, Olivia. Right to be concerned. I will say I haven't spent a lot of time in Section B, but there does seem to be a lot of confusion about why we are starting at 2019 levels and what the path forward is. So that's not particularly helpful, but I do think when we move out of the subcommittee process and into full appropriations, there might be a clearer path forward for where and how we can advocate to build some of that budget back in.
Thanks, Howell. But I think as you're listening to, as you get kind of Montana Women Vote action alerts and you're like, section B, do I really need to pay attention? I think we really need to pay attention. We always need to pay attention. There are lots and lots of programs and services that matter deeply to low-income folks, people with disabilities, people who have people who are vulnerable. Like, there are all kinds of programs and services that are decided in section B in terms of their level of funding. And so we should always pay attention to section B. But it's where we're also thinking about Medicaid expansion, I think, in a different way than we have in past sessions, right? Like in past sessions, it's like, this is the bill that's going to repeal it. This is the bill that's going to pass it. So I think it's more of an insider game a little bit. So reading those action alerts is super important to kind of track what's going on. And the folks from Montana Women Vote know better than anybody what's going on. So listen to them. Other questions about Medicaid expansion while Howell is unmuted?
I'll just say one more thing. I mean, Olivia got it exactly right that we're not facing a sort of full repeal of Medicaid expansion this session, which is good. And I think it's important for us not to rule out that possibility down the line. And one of the things that could lead to a deeper discussion next session or 2 sessions from now about repealing Medicaid expansion is a program that doesn't work very well. And what makes a program not work very well? When we don't invest in it, when it's not fully staffed, when people have to fight through a bunch of bureaucracy and red tape to get enrolled and stay enrolled. So I do think that we need to take what seems like small sort of nibbling around the edges attacks this session pretty seriously, because they do feed into a deeper, longer term strategy to ultimately roll back expansion or, look to a much different vision of healthcare for low income folks in this state. So I just want to add that perspective in.
And we do just briefly have one other Medicaid expansion related question, which is also pandemic related. One of our participants is concerned about Medicaid expansion and increasing the funding for home and community-based services for aging folks and folks living with disabilities, in terms of keeping them out of homes and getting them out of some of these facilities where 40% of the COVID deaths have occurred, and provided livable wages for attendance and PPE. So I know that this is a big question, but if there's any part of that question that you want to address now, I just wanted to put that one out there.
Yeah, I think that that's a great question. Howell, do you want to, so I don't have the answer. I'm not sure where the home and community-based services, where the funding is trending and kind of what folks are hearing. Howell, do you have any, does anybody else who kind of is in the halls or in the virtuals of the Capitol? I don't have I can find out an answer to that, but I don't know that.
I don't know the answer on that specifically either, but we can get that answer and send it on to whoever asked that question. It's a good question.
The other piece of that brings up, I know there's lots of conversations, and you saw some of what's happening with some of the federal COVID money, relief money, whatever you call it, right? Looking at kind of behavioral health, looking at specifically mental health and substance use disorder treatment. And I know there's lots of conversations happening around The governor does seem interested in increasing substance use disorder treatment. There's some conversation about whether or not that the proposal is pulling some of the money out of the marijuana initiative, and there's lots of feelings about if that's what was passed by the voters and what is potentially happening. But so that funding is super important. And for folks who are Medicaid eligible, right, we need to be funding both Medicaid, because Medicaid provides comprehensive coverage, including mental health, behavioral health, substance use disorder treatment services, and also funding specific substance use disorder treatment services as well. So I think I think it's a both and conversation as we're thinking about responding to needs around behavioral health in communities across the state, which was happening certainly before the pandemic, but we've seen an increase post-pandemic as well. And I have a lot of smart colleagues who, if you have good questions, I will happily connect you to them because they do that work all day long about integrated behavioral health. Okay, so I'm gonna do a time check, Ella. It's 1:24. I'm gonna show one more. I thought we would run out of time. I apologize. So I wanted to show, I know this question came up about kind of part of what the Montana Healthcare Foundation does, right, to help ensure we have the information to make kind of smart policy decisions about programs and services is do these really great studies and really kind of make the data make sense to people and look beautiful. This is a recent Medicaid in Montana. They did 2 reports recently that are on their website. And what I think is you can see kind of what the Medicaid enrollment breakdown looks like for both the state, right, overall, and then the Medicaid breakdown. So, so Indigenous people in Montana make up 6% of the population, but 18% of the Medicaid rolls. And then if you look at the gender breakdown, that is unsurprising. We know that women access more healthcare services and make more decisions about healthcare services. When I'm talking to somebody trying to get folks to enroll to learn about health insurance marketplace coverage, I'm trying to talk to women because they're paying attention. And then you can kind of see the impact of the geography, that the state is mostly rural and Medicaid expansion is mostly, there's a bigger number of folks in rural places that are enrolled. So it's a hugely important program for rural places. There's lots of discussions about, keeping hospital doors open and keeping healthcare providers in small towns. And Medicaid is hugely important in ensuring that. Montana hasn't had a hospital close since 2010 in the same way that other states have. And so I think, and that data, if you look at Medicaid expansion states, non-Medicaid expansion states, that's a big deal. I have more Medicaid expansion slides that I wanted to highlight, but I also want to pause and you all can download this beautiful report and look at them yourself. So if there's I'll pull this one up. It's about telehealth. And part of the reason why telehealth is so important is because a lot of those telehealth visits are behavioral health visits. So it's somebody having mental health or substance use disorder treatment over kind of a telehealth platform. And I'll also say that we say telehealth, but a lot of telehealth visits are phone visits. So I guess it makes sense. It's telehealth, not Zoom health. Sometimes it's Zoom, but it's not always somebody talking to a provider on a phone. I will pause.
And Olivia, could you speak to the growth and sustainability of telehealth as a viable and reimbursable service to increase access to health services?
Yeah, so I think telehealth so the telehealth rules, right? Like who can access telehealth from where and kind of what constitutes a telehealth visit and whether or not you get paid the same amount as an in-person visit has all shifted during COVID. We've been talking about telehealth in healthcare for a very long time. And and COVID has just like pushed it, like kind of blown the doors off of what telehealth, what the amount of services that are being provided via telehealth. I mean, and I think that's in part because of payment. And so I think that, so for folks, so I think it's really important for both patients, right, who are accessing care and able to actually see a provider if they live far away from a provider. And it's also really helpful for providers to be able to check in with their patients who, might have a chronic disease, and maybe they have diabetes or high blood pressure. And there's all this really interesting kind of remote patient monitoring going on where your provider doesn't have to see you, but you can still kind of meet with them and get that support. So I think it's really exciting. I think that what we see with the broadband funding at the federal level is that not everybody is able to access in the same way. So how do we ensure that we're not further exacerbating disparities in access, right, through telehealth? I think that, we could very well see that, like, great, everybody has more access, except the people who didn't have access before continue to not have access. And so how do we both make sure that we're expanding, but also keeping an eye to making sure that we're addressing the disparities and the access piece? So I think the other thing about, the place where telehealth has also existed a lot is if you have a health insurance plan, your health insurer might say, well, great, Olivia, you get 3 primary care visits with, X, Y, and Z health insurers provider, which are telehealth visits. And so I think that it's interesting for kind of clinics and hospitals, kind of the telehealth access. And then I think that there's a lot of questions on what this looks like if Amazon is providing telehealth next year, right? Which is totally within the realm of what could happen, right? Like, I think that there's further conversations about what that means for quality. Like, it certainly is access, but does it matter that people have a relationship with a provider? I am biased. I think yes, right? But if you're in a rural place and you can't have a relationship with a provider because you couldn't afford one before, is it better than nothing? Probably. I think that telehealth conversation will continue, and it is ongoing. I don't know if I answered any of the questions.
You definitely did, and we actually got to a lot of the questions in some of the content throughout. We do have a few other questions that we unfortunately did not have the time to get to today, particularly about rural healthcare, as well as some of the very specific questions about intersections with the missing and murdered Indigenous people and maternal health disparities for missing and murdered or maternal health disparities for people of color, Black, Indigenous communities. So I would love, Olivia, if you might be willing to share whatever your preferred contact information is in the chat box. So for folks who might have had additional questions come up, or if we didn't end up having the time to get to your question today, please feel free to email Olivia at the email just dropped into the chat box. Or get in touch with us at Montana Women Vote, and we will make sure to get information to you and chat about any further questions that you might have. And before I let Olivia say goodbye, I just wanted to briefly direct everybody to our evaluations for the Women's Policy Leadership Institute. These evaluations are really important and helpful to us in terms of crafting our future programming and making sure that we're providing helpful information for the folks who are engaging with our work. And Rachel, if you would be willing to drop that evaluation link into the chat. If you put your name at the end of the evaluation, you are entered to win a prize. We'll be drawing 8 names at the end of the Women's Policy Leadership Institute, and you will either win a $25 Visa gift card or a copy of Horsefly Dress, a beautiful book of poetry by local author Heather Cahoon. So you can fill out the evaluation after every session and then again at the very end. And every time you fill it out is an additional entry into the raffle. So thank you so much, everybody, for joining. And thank you, Olivia. I'll let you say any closing words that you might have for folks.
Thank you. I think if you have more questions, reach out to me. We do a bunch of trainings at the Primary Care Association, and anybody is allowed to kind of hop on those. So if there's more wonky healthcare stuff that you want to kind of keep your ear to, we welcome you to hop on our email listservs and join our trainings as well. But thank you, Montana Women Vote, for all that you do always. One day we won't have to have this healthcare session talking about Medicaid expansion at a WPLI, but until then, I'm always happy to be a part of it. And thanks everybody for taking the time.